objectivity or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Thanks, Kelly, and good evening, everyone. I want to thank you all for joining us for another webinar in our series on anxiety. If you've missed any of the previous webinars in this series or any other webinars that you'd like to take a listen to, be sure to find them archived on our website. Tonight's webinar will focus on childhood anxiety and what the current treatment modalities entail. To present tonight's program, I'm pleased to introduce Dr. Diana Antinoro, who specializes in treating children, adults, and families affected by anxiety, tics, trichotillomania, and related disorders in addition to behavioral difficulties. Dr. Antinoro received her undergraduate degree from New York University and her doctorate in clinical psychology from Rutgers University Graduate School of Applied and Professional Psychology. While in the graduate program at Rutgers, she was a clinician in our affiliated Tourette syndrome practicum, working with kids and adolescents living with TS. Currently, she is clinical director of the Child and Adolescent OCD, tic, trichotillomania, and anxiety group in the Department of Psychiatry at the University of Pennsylvania School of Medicine. Her clinical and research interests include therapy for children and adults with anxiety, OCD, tic disorders, and trichotillomania, as well as investigating treatment effectiveness. Dr. Antinoro, welcome. It's a pleasure to have you join our webinar tonight, and I look forward to your presentation.
Thank you, Marty, for that introduction. It's a pleasure to be here tonight with you all, and I hope we can get through much of this tonight. We tend to actually present a lot of this material in a full-day workshop, so to cut it back to an hour is quite difficult. I'm excited to be here and speak with you all about child anxiety. I hope you can all see my screen.
Yes, we can see your screen.
Okay, thank you. So I'm here to present material on child anxiety, specifically to discuss what treatment entails for the child and the family. Some of this is going to be sort of briefly reviewed, just so that we can get some basic background information, and I'd like us to continue to the material a little bit quickly at first so that we can get to the end and get to the crux of our material. So in general, I will review with you what common childhood anxiety disorders there are, and the ones we tend to see most commonly in our clinic. We'll also discuss when it's time for us to do more than simply manage it at home. We will then identify which treatments are available and what the research tends to say about those treatments, and also see if there are some self-help resources, both for parents, teachers, and children. In the long run, I hope that parents, as well as all other adults in the lives of these children, can find out what they can do to help, specifically gaining the principles of CBT and how it applies to anxiety, and then to discuss some particular strategies that might be helpful and how parents and even teachers can help out with regard to treatment. I'll run through this slide pretty quickly because I imagine that most of you have heard of some of these disorders in the past. Typically, anxiety disorders in youth are very common. We tend to see quite a bit of individuals coming in with disorders presenting between the ages of 3 to 15 is the most of our clinic right now. Individuals tend to present with this list, which is the list of most common disorders. When it comes to separation anxiety, I'm sure most of you have heard of this as a concern. We often tend to see this in younger kids. Typically, it's a concern about being away from parents, as well as a concern that something bad might actually happen to the child or the parent when separated. Social anxiety and selective mutism, the second point there, is actually combined because both of them are triggered by social situations, in the sense that whenever in a social situation, the person will be hyper aware of their performance and concerned about negative criticism or potentially embarrassment. With regard to selective mutism, the individual also has great difficulty speaking, whether it be at all in public or in specific situations. Generalized anxiety disorder is typically something that presents as worries. We call it sort of the worry of the day or the worry du jour. In a sense, individuals with this type of disorder tend to have worries that are exacerbated or more present for them in their life than the rest of us. We all have some worries, whether it be about school, work, making appointments on time, but these individuals do seriously have much more time spent worrying about this and also much more distress with regard to those specific things. Specific phobia is something that many of us have also heard of, which is a particular fear in relation to a particular item. So it can be phobia of spiders, elevators, costumed characters, and so on. Panic disorder tends to be more of a focus on the individual's physiological arousal. Physiological arousal can look like anything from increased heart rate to sweating and redness in the face, feeling dizzy, or feeling as if the individual may actually vomit. Obsessive-compulsive disorder and post-traumatic stress disorder at the bottom of the list are actually highlighted in white because they're slightly different with regard to treatment than the other disorders, and we can talk about that a little bit more later. But OCD is commonly presented in the media with regard to contamination concerns, so individuals will wash their hands more times than the rest of the typical population. But OCD generally can look like anything from having intrusive thoughts about death or having an uneasiness or feeling like something is just not right, which leads them to do things repetitively or until they feel better. And post-traumatic stress disorder is sometimes seen with individuals and adults, but largely it's after having a traumatic experience and then having that experience stick with the individual. In a sense, their thoughts about it are intrusive. It is hard for them to almost let down their guard. The key I would like you to take away from all of this is that, in general, when we're looking at disorders, we want to identify this intense or out of proportion anxiety that is resulting in distress or functional impairment. So those are the two keys to figuring out whether or not this individual may actually need more specific help than simply trial and error or seeing if it just goes away on its own. Some people actually do tell us, oh, everybody has anxiety. Why pay attention to it? Why enroll a child in a treatment program for it? It is true that most of us do have some anxiety here and there, and it's very much a part of natural life. But in general, we do see 12 to 20% of children experiencing an anxiety disorder. And these anxiety disorders tend to have a negative impact in many areas of their life, including educational underachievement. So they may not enter college, or they may not be able to achieve scores that are as high as they would have otherwise, which then, of course, has impacts on their long-term career goals. In addition to that, we see some derailing from other important developmental milestones. In a sense, they may not be able to gain those skills, either on time or even at all. A majority of the children that we tend to see do sort of inevitably gain those milestones at some point, but they may actually be slightly delayed or potentially challenged in those moments. So some of those situations are dating, being able to stay organized for exams or school or work or things of that sort. Oftentimes we also see childhood anxiety associated with depression and or some suicidal thoughts. Typically, this is usually at one end of the spectrum in which the anxiety has become so intense that overall the anxiety is not letting the child live their life, and it's interfering so much that the child has pretty much almost refrained from doing many of the typical things that their peers would be doing. In addition to those components with regard to childhood difficulty that the person may experience, when we take a longer term look into adulthood, we tend to see a little bit more substance abuse, some depression, as well as other anxiety disorders in adulthood. So that's just to give you somewhat of a sense as to why we think it's so important to actually almost nip it in the bud, get it before we can see all of its ramifications or consequences thereafter. So the key to the next step is, when do we actually feel like it's important to do more? How do we know that treatment is actually appropriate? One thing I do want to highlight is that fears and anxieties are normal for all of us to have at certain points in our lives, and if children weren't expressing those things, we'd be actually more concerned. This list tends to present some of the common fears or anxieties that children will experience, both in their earlier years, preschool years, school age, as well as high school. And you can take a quick peek at those in the sense that stranger anxiety is very common with our youngsters. Preschool separation becomes a very important, difficult moment for these children and parents as well. And then with school age, of course, there's more of a concern about social evaluation, as well as in high school, which the individuals tend to worry a little bit more about things that adults seem to also worry about, doing well, more of the long-term future worries. So all of these are normal and expected with children in general as they go through these transitions. Our main goal here is to say that we expect this to happen, but we want them to be just present for that period of time and not prevent the child from actually living their life the way that they'd like to. So when we think about whether or not anxiety is a disorder, we tend to pay attention to these four main characteristics. Is there greater avoidance in situations than would be expected with their peers? So is the child unable to call a friend to come over because of concern that the friend may say no? Is the child refraining from engaging in certain activities, whether it be showering because it may be too difficult, or whether it be taking a test because that worry about the test is too intense for them? We look at interference as well. So is it taking the family 2 hours to get out of the house in the morning? Do we need a rally or a set of 10 hands to help us move along in our day? That's a little bit more extreme than is typical, I think, with most of our kids with an anxiety disorder. But if we're seeing, even 30, 40 minutes of a delay in the morning, it tends to concern us a little bit. So we want to see at home, in school, and with friends, is the anxiety actually getting in their way, preventing them from doing something that we know they have the skills to do? Distress is another area in which we tend to pay attention to. So if the individual is worried about their test for a few weeks prior to the test, it's not a major test, it's not a final, most of their peers are not thinking about it at this point, and the anxiety is so high, we would tend to be concerned about the level of distress that this individual is experiencing and wonder if we can help them to manage those moments better. As well as duration, which is the last component there that we tend to pay attention to. So if a person is concerned about separation from their parents, we would tend to look and see, are they thinking about it weeks in advance? Are they thinking about it after their parent has come back? And in general, these 4 points are really important for us all to be thinking about whether or not, when we are deciding whether or not treatment may be helpful. With that basic premise, I want us to go into the next steps in which we do encourage parents to obtain a full evaluation if you feel like your child is struggling with an anxiety disorder or even just anxiety concerns. And what the next part of our section, of our talk tonight will be specifically discussing what can parents actually do. So I'm going to be spending a lot of time talking about what treatment options there are, in particular CBT, or cognitive behavioral therapy. We do have research showing that medication, CBT, and the combination of those two are quite effective, and we'll talk slightly about that, as well as discuss the principles of CBT and then how parents can actually use certain strategies to help their children in these moments. When we look to find treatments that work for any disorder, we tend to look to randomized controlled trials. These are the gold standards of research, and we tend to look at them because they have sort of the most robust findings and tend to have the largest sampling of patients. We have plenty of research showing that pharmacology, particularly SSRIs, can be quite helpful for individuals. We have a lot of research also indicating that cognitive behavioral therapy can be highly successful at helping the individual reduce the interference and symptoms. And also, more recently, we've seen quite a number of studies coming out looking at the combination of both CBT and SSRIs. I will spend most of my time talking about CBT because, of course, that's my specialty. But you know, definitely, with regard to the randomized controlled trials on this last page, we definitely encourage a lot of our patients to explore the pharmacology if that's something that they do wish to do so. Now, I'll take I just want to give you a little bit of background information on this slide. This particular treatment protocol was actually created by Dr. Phil Kendall at Temple University. And this slide actually shows the outcomes of treatment at 2 separate times. Now, I'll take a quick second for you to just take a peek at what I'm going to be describing. I want you to see that the orange is all the individuals that have actually responded, which basically means they came into treatment with a diagnosis of an anxiety disorder, and then at the end of their treatment, which is a 16-week protocol of CBT, they no longer had a diagnosis. So those are the individuals who went from full diagnosis to no diagnosis, meaning their symptoms and their interference have dropped significantly. In addition to exploring how the CBT protocol worked, Dr. Kendall also ended up implementing a wait list control to see if individuals would inevitably just have their anxiety symptoms decrease, or sometimes we do see individuals get better simply by thinking they're doing something about their anxiety. So that's what the wait list control is there to actually compare, whether or not it's just a feeling of I'm doing something about it, or if the actual treatment itself was highly effective. What you'll see here is that somewhere between 62% and about 55% of the children that were enrolled in this study actually came to the end of the protocol and had no diagnostic criterion that would meet for an anxiety disorder. So they may have some symptoms, but they definitely did not still have an anxiety diagnosis, which is great, meaning their interference had dropped, and in general, they probably were functioning much better. So this protocol, one thing I do want you to recognize is that the coping kit is actually done with children who have most of the anxiety disorder diagnoses that we talked about. It is not used for OCD and or PTSD, or post-traumatic stress disorder. This slide also presents another CBT protocol, particularly focused on OCD. And this study was done with the help of researchers at Penn, at Duke, as well as at Brown. And in general, what they were trying to do here is to see, for OCD, what is the best method by which we go about treating these individuals. So they were all children. You're seeing what we call the Psy.D total that's listed here. And that pretty much is an assessment of OCD severity. So if you see on this side, the 0 to 30, a 25 is about moderate severity, not terribly severe in the sense that they would not be functioning at all, but serious enough that there's some interference, much distress, and probably a great amount of accommodation or an impact on the family. So we actually had 4 separate groups here. One group, the orange, is actually the placebo or fake medicine. So individuals were given a sugar pill. The red is sertraline, which is an SSRI. The green is CBT, which was an adaptation of one of John March's protocols. And the yellow is the combined treatment. So individuals were given both sertraline and CBT. And as you can see, the orange actually didn't do so much better, but really when you took a look at it statistically, it actually made no improvement. So fake medicine did not work. The red, or sertraline, ended up giving us a pretty nice reduction from 25 down to about 15. And I'll have to say that 15 is subclinical. Below 15 is subclinical. So that's sort of our target. We want to get children and adults actually below that 15. And the green, CBT, again, went from about 26, maybe 27, down to 15, showing, again, a nice reduction. And the yellow actually gave us the biggest reduction, which is spectacular, to show that all of these active treatments, the medication, the CBT, and the combined treatment, work quite well. What I'd like you to get from those 2 studies, and that's just a sampling of many, many, many studies out there, but in general we want to know that medication alone is helpful. And unfortunately a lot of patients do start with medication and still have remaining symptoms and or a diagnosis that's still currently present for them. So that means that there's still enough interference in their life. CBT alone produces a greater chance of remission than medication alone, and this is sort of just an assumption. I would love to see a lot more research on this, but we do feel like the medication sees a nice reduction in symptoms, and the CBT would hopefully increase in its effectiveness because the individual will continue to use those skills and become more of a master at it. So they may actually continue to see a decrease past that 12-week mark at the end of treatment. The combination of both the CBT and medication provides the best chance of remission. So it's the quickest and fastest way of getting down in our symptoms and our interference, which is great to know, especially for individuals who are having quite significant severity with these symptoms. In addition to that, we tend to encourage most of our children and adolescents to either start with CBT alone or the combination of CBT and medication. Not that we don't feel like medication could be a treatment by itself, but oftentimes we do feel like there is that potential to engage in CBT and see a pretty good reduction in interference. So we would like to see if that works first. So now I'll go into what CBT for pediatric anxiety and OCD looks like. Again, this is quite a bit of information that I've compacted, but I want you to definitely get the basic principles, and if you have any questions throughout this, please do feel free to send them to Marty or Kelly. For those of you who are not so familiar with cognitive behavioral therapy, the thing I want to highlight for you here is that we tend to pay great attention to our cognitions or our thoughts, which is over here in the top left-hand corner, and our behaviors. So how are we thinking and how are we acting in these situations? I'd like us to take an example so that I have you go through some of the experiences that some of our individuals that we see here can experience in some of their anxiety situations, and to grasp how these pieces are all connected. So let's start out in our top left-hand corner. If an individual has, let's say for instance in this case, a social anxiety, so they are concerned about their appearance and performance in a social situation, and they're approaching a social situation, say a group of peers, they may in fact have an immediate thought of, they'll think I'm stupid over here. And we call this an anxious interpretation or a prediction of a feared outcome. Some may call it catastrophizing. There are many different ways of discussing what that reaction is. But the key to this is that when we have this thought, it's actually going to make us feel more nervous, which then leads us to this next component here, which is the physiological component, or the body sensations. So the individual may then start to have their heart race, or start to get flustered, not be able to focus on the actual social situation, but now they're hyper-focused on their body and how they're feeling in that moment. They may get dizzy, they may have muscle tension, and various other body sensations can co-occur with all of this. As we go and we see how we're having these thoughts and these body sensations, we tend to also notice that anybody in this situation would likely want to avoid or escape. Whenever our body is telling us it's a danger, and that's exactly what we think is going on here. When your body starts to react like this, it's going to tell us it's a real danger. We cannot handle this moment. So most oftentimes, when we're in a dangerous situation, we tend to avoid or escape. The difficulty with this is that then once the individual avoids or escapes, they'll get some relief at first, which we think we all want in that moment. But the difficulty with that is then all of a sudden, the next time the person enters that situation again, the likelihood of them having this same reaction goes up. So they are more likely to again interpret the situation in this negative way, have these symptoms, and escape. Unfortunately, we even see an increase in that anxiety in the future. So we do want to cut that off. And the way we cut that off is actually by stopping the behavioral avoidance. And that is the exposure component of CBT treatment for anxiety, which we'll talk about in a few minutes. This bottom part here that says negative reinforcement basically means that we're going to keep on doing this because it made us feel better. Every time we get into an anxious situation, we will inevitably continue to avoid. This graph provides a little bit more detail as to what the individual's experience is. So as you can see, as avoidance makes us feel better, each time we go back into the situation, we're going to continue to have that same initial reaction of anxiety. So let's start over here. We start to feel nervous about entering that social situation. We may avoid when it peaks, feel slightly better, or completely better because we're out of that situation. But the next time we're in that situation, it happens again and again. So despite the fact that the avoidance helps us in the immediate time period, what it actually does is set us up for more failure in the future because we will continue to have the same reaction or even a more heightened reaction. With regard to CBT, we feel like the adaptive cycle is an approach cycle. We call it behavioral exposure. And the basic crux of it is we want to put ourselves in the experience that's causing us anxiety, get to the point where it peaks, and it may actually peak higher than it would have been if we had avoided it in the first place. But once it peaks, we tend to see it dropping. Your body just naturally brings it back down. We fortunately cannot stay anxious for that long. Most of our individuals that we tend to see, especially when doing exposures, will see their anxiety drop within 20 to 40 minutes. Some of our real younger guys can actually experience that drop in 5 to 10 minutes. But the key is letting us go through this first step of letting the anxiety come and then letting it go. And if we can do that, then we get the true payoff, because the second time the anxiety comes and we see that it's not as intense, number one, and it actually takes less time for it to drop. So the duration and the intensity of it does not get worse, it actually gets better pretty quickly. And over time we tend to see it drop again and again. You get this nice rainbow pattern on here. The key also to this is that inevitably we hope that we get sort of this flat line at the bottom, or maybe a tiny little bump that says, oh, I used to be nervous in that social situation, but no more. So it gets easier with each experience. With regard to treatment, we tend to think of it as a 12 to 20 session protocol. Some individuals can do it a little bit faster, some take a little bit longer. With regard to younger children or older children, we don't sort of change the number of sessions, but we tend to change the content of the sessions. So as we walk through this, I want you to think about these as main components of the treatment, but with a 5-year-old, we would be presenting this in a very different model as opposed to working with an 18-year-old or a 15-year-old. We tend to be a little bit more playful with our younger ones and use some more toys or games or what have you. So if you end up seeing any of us here at some point, you'll see some potential use of puppets or games or even just some acting out of some emotions, so like some feeling charades. In general, what our main goals of treatment are to provide these particular skills for the individual. One is to know what our emotions are and identify them with greater ease and understand why emotions are present. In addition to that, we tend to look to describing what our body does when we're having these certain emotions. And if we're aware of what our emotions are and what it does to our bodies and to our minds, it actually helps the individual to manage those situations quite a bit better. So once we get to the point where the child is more able to understand their emotions, identify them, and grasp what's going on with their body, we tend to use some relaxation strategies. Some of them are progressive muscle relaxation. Some of them can include more of a meditation or yoga approach. But overall, we try to tailor it to whatever the individual seems to like. So if they're more of an active person, muscle relaxation would probably be the way to go. The next point is about anxious thoughts or paying attention to our cognitions here. So we want to identify and change those anxious thoughts. That's the C in the CBT protocol. I'll talk about that in a couple of seconds in more depth. We also provide some problem-solving skills so that the individual can handle difficult situations because we know that they come up. And then the other major component of the treatment besides the cognitive piece is graded exposure, which is what I just described for you with that rainbow effect in the sense that individuals are asked to enter those anxious situations and to actually see themselves do well in it despite their thoughts that they can't. And we'll talk a little bit more about that. When we work on cognitive change, we want to understand what this cognitive restructuring is. And we don't use these terms with our real young individuals. But the main component of this is identifying those negative or harmful thoughts and replacing them with positive, neutral, or even what we say helpful thoughts. So it might not be positive in the sense like I can actually go and do this social activity perfectly well, because I don't know if that individual is going to really be able to believe that. But I'd rather them say, maybe I give it a shot and it could turn out well. You never know. So taking a look at this glass as half full versus half empty. We don't want the individual to feel the pressure to see it as fully positive or perfect because that would probably prevent them from using those skills in the future. So the basics of this cognitive restructuring is to identify our self-talk or automatic thoughts and notice where they pop up. They actually are not intentional. We all have self-talk that pops up in any moment of our lives. And some of the times it's quite helpful. Some of the times it's actually quite hurtful. And those thoughts actually change how we see the situation. So if you're late to work and your train is late, on top of that, if you start thinking, I'm never going to get there for this meeting, it's actually going to trigger more anxiety, more distress. But if you can say to yourself, okay, you know what, I actually have nothing to do here. The train's late. I'm just going to call ahead and let them know. There's not much else to do. I think that actually will decrease the individual's distress and or anxiety in that moment. And it's just a mere switch of the way we're thinking about that situation. So again, we want to find which ones are helpful, neutral, or hurtful. Identify those thoughts and treat them almost as if hypotheses, especially the hurtful ones. If we're predicting the worst, we don't want to believe that as a fact. We want to then develop ways to dispute those self-talk thoughts, and actually then create a rational response. Next, I want us to take a quick peek at coping thoughts. And this is sort of just a cute little description that shows certain things that we call thinking traps. So thinking you have to be perfect, and or expecting yourself to be a perfectionist. And then the coping thought would be, we're human, nobody's perfect. And we would initially provide some examples of this for the children. Depending on their age, we then encourage them to do some of this on their own, and we would love to have parents be involved with this as well. The last two I'm not going to actually go through just because I want to save us a little bit of time for discussion as well. When it comes to the behavioral change or the principles of exposure, I'd like us to take a quick peek at the main goals that we have in mind here. So we want to actually engage in the anxiety-provoking situation and not avoid, in order to actually feel the anxiety and remain in the situation until it actually becomes easier or the anxiety decreases. In a benign situation, the person tends to actually experience habituation or a decrease in their feeling of anxiety. We would see that we no longer would respond to the anxiety without that stimulus being a genuine threat. So if we feel like a social situation would be difficult and we enter it and we see that we actually do well, then you know what happens? We actually see that that thought was actually incorrect. And overall, we can actually enter that situation with a little bit more ease in the future. We tend to use a hierarchy or start out with things that are slightly easier for the individual and then work our way up to more and more challenging tests. The goal here is to provide the experience by performing in and managing the anxious situation. We don't expect perfection, but we do expect the individual to try it and see how it goes. Most of the time, the individual does better than what they actually thought they would be able to do in those situations. We want to practice and refine these cognitive skills, social skills, and problem-solving skills in the real-life anxiety-provoking situations. We want to, again, practice those skills at refuting those negative automatic thoughts while they're their most intense. And then, in the long run, obtain this confidence that they can manage the difficult situation and the anxiety. So overall, our intention at the end of all this treatment is to actually have the individual experience habituation to anxiety. And when I say habituation to anxiety, I mean it's a complete switch in how the person interacts with anxiety. They are no more afraid of anxiety, but they almost expect it to be there, can see it, and continue to live their life with or without it. This is just a simple illustration of something we use within our treatments to describe how difficult things are for individuals. This is our fear thermometer, which helps all of us to grasp what level of distress the individual is experiencing and how difficult it is for the child and how much we can challenge them. So I'm sorry I'm running through this a little bit fast, but I wanted to make sure we get to the end and leave some time for phone calls. Overall, what parents and adults can do is quite a bit, actually, especially for our younger ones. In general, we do feel like parents and teachers and other adults in their lives have a great influence on how children interact with their anxiety. So they can encourage them to face their fears, which could be a simple exposure at home, or they can encourage them to avoid their fears by saying, oh, that may be too much for you. Let's not try that today. In addition to that, we do see that children do learn quite a bit through modeling. So having a parent approach a situation that's difficult for them may in fact provide the child with an opportunity to think about how they can manage a difficult situation. And if they see their parent avoid a difficult situation, it may in fact encourage the child to do similar things. One of the biggest things we tend to see both in treatment and sort of just outside of treatment is that it is quite difficult for parents to see their children in distress. So in the long run, we are actually almost even asking the parents to be okay with seeing their child get anxious and actually to encourage it in certain moments. Because if they're able to experience that anxiety and do well in that situation, that anxiety will inevitably decrease over time. Within the treatment, we also want children to be supported, both for doing the treatment, making sure that it transfers to their home life, and also ensuring that over time we see that they're able to manage these concerns throughout their lives. Overall, we tend to encourage families to have more of a focus on functioning as opposed to relief from anxiety. So when I see an individual and I want to hear how their week has gone, I tend to listen first. So if they come in and they say, oh, I had a great week, or oh, I had a horrible week, I want them to describe to me what that means. So if a great week is, I had no anxiety, no problem, great, that might in fact be great. But if they come in and said, I had a horrible week, I was anxious almost every day, I want to hear, well, what did you do when you were anxious? If you avoided, then that might actually be a not so great week. If we actually approached it, then I would say that that indicates to me that you had a great week, even better than having no anxiety because you challenged it and you won. Overall, we try to encourage parents to decrease that accommodation and increase the use of those adaptive skills in managing anxiety. Some of the simpler strategies that we tend to use both in treatment and encourage parents to use outside is to externalize the anxiety. So calling the anxiety a name, such as the worry bug, drawing a picture of the anxiety so the child has that external representation of the enemy. Overall, these strategies of externalizing or placing the anxiety outside of the child can help both the child and the family to get separation from it. The child may feel less blame and actually may be more motivated to challenge it. It can make it even easier to have a game or a battle with the anxiety as opposed to their own thoughts or feelings. In addition, we tend to encourage an acceptance approach. So we want children to be able to express their anxiety and express their feelings, and for the parents to empathize with that, which is great. Sometimes children don't know how to actually express these things, so we encourage families and we encourage all of our therapists to actually provide a way for children to discuss these things, and almost even provide a vocabulary for them. We want to be able to recognize that uncomfortable feelings can occur for anybody, including children, parents, etc., and that all of us can actually manage those feelings, even though they're uncomfortable. And we also, again, want to refocus our attention away from the feelings of anxiety to how are we doing in life? Are we being flexible? Are we functioning at our best? Overall, I'd like us to just take a quick peek at the difference between rewards and accommodation. Rewards are great for children in general. They can be immensely motivating. And with regard to these types of treatments, we're asking children to do things that are the hardest for them. So we want to encourage them to actually engage in these tasks and potentially give them a reward for doing so. So we identify those targets of the rewards and those behaviors, and we want to focus on the child's interests and strengths as well. The accommodation concern is that oftentimes if children are having things done for them, whether it be making their own lunch because they can't go in the refrigerator for fear of a certain food, or if parents are helping them by packing their backpack because they would check it too many times, we would encourage parents to slowly fade out that accommodation. We know that accommodation decreases the motivation for children to change, and we know it's quite difficult for both the child and the parent to change that, but we think it's quite helpful in the long run, and it prevents further exposure and avoidance difficulties for reinforcing the anxiety. Overall, I'd like to also think about resistance, both to treatment as well as managing the situations in real life. Does the child actually understand what to expect? Are helpful phrases becoming aversive? So have we used something a little bit too much here? In general, we also would like to think about which challenging situations we're approaching, and are we actually asking the child to do something that's too difficult here? Maybe we need to take a step back. Instead of approaching a group of peers, in maybe a group of 7 peers, maybe start with one person who is mildly familiar and may be able to make the social transition a little bit easier for the child. In general, we also want to take this as an opportunity to show that this is an opportunity for the child to challenge the anxiety. We want them to recognize that, okay, this is a moment for you to actually take back that power from anxiety as opposed to hand it over. And we also want to always express our support, both by not providing accommodation and showing that we want to follow through on the situation. Even if it's too difficult now, our ultimate goal is to stick with it and get there in the long run. The next few slides are just sort of quick online resources and other resources. All of these websites are very helpful, both to therapists, teachers, as well as parents. I would encourage you to explore them based on the particular needs or concerns that you have. Here are some books for parents and teachers, and particularly giving a little bit more background. Some of them are more targeted to anxiety and how parents or teachers can help. Some of them are a little bit more targeted towards OCD and a little bit more about medications. These are some books for children, which actually provides very similar information that we've talked about tonight, but in general it gives a little bit more of a story context in a lot of these and can help the child to relate to some of these other children that they're describing in these books. Again, some of them are more particularly OCD, and those are sort of marked off to the side. One thing I do want you to know is that overall, OCD treatment tends to actually focus a little bit less on the cognitive components. So we think OCD, unfortunately, is not necessarily typically rational. So the individual who has to wash their hands 6 times knows that washing their hands would probably not really do that much. They just feel that they have to do it that number of times. So we tend not to actually challenge those thoughts in those moments with OCD. We tend to actually just sort of externalize it, recognize it as OCD, and then move on directly to the behavioral exposure. And again, I'd like just to mention throughout all of this, each individual child has a particular set of symptoms that are unique to them. So despite the fact that there's a protocol here that I've introduced and sort of run through quite quickly, I would definitely want you to think about how it is totally tailored to each and every child that is presented, and it does really need to be tailored to their specific symptoms, because otherwise we would never be able to get the success that we tend to get with some of these children. And so if you have any questions or concerns, this is sort of our group at Penn. This is our specialty and what we have available to both the community, parents, teachers, schools, etc. And you can find us at that website. Our research assistants actually are really great at talking with parents, even if you don't want to come in for an assessment or anything like that. If you just want to sort of bat around some ideas, they're really great at sort of helping you to sort some things out and see what's the next best step. And thank you.
Well, thank you. A lot of great information, and we actually have a fair number of questions that have popped up. So I think I'm going to start immediately with the Q&A.
Okay.
Okay, are you ready?
Sure.
As a parent of a young teen, you had a slide about potential effects of untreated anxiety, and
yes.
they're disturbing. So would you elaborate a little more about more on the prevalence of problems in adulthood with untreated childhood anxiety?
Absolutely. Let me go back to that slide, if I can.
It was kind of near the beginning, I
Yep.
thought, but.
So I believe this is the slide you're describing, and so I'll bring it up for everyone. So yes, the material presented on this slide can be definitely disturbing, concerning. We present it here because we do have some people who do say that anxiety is something that's typical, and why should we worry about it? The thing I do want most parents and professionals to know is that a lot of these children with anxiety do quite well in life. They do have interference. So if it's social anxiety, they're going to have more of a difficult time managing their developmental milestones in the social realm. If they have worries about school, they may actually have more of an interference in that area. So when I think about anxiety disorders as a whole, I don't want to paint this catastrophic picture for sure, because that's definitely not the case. The research does show that unfortunately over time, and especially as anxiety disorders are comorbid with one another, so if the anxiety disorder remains throughout adulthood, and if the individual has 2 or 3 or more anxiety disorders, the individual is much more likely to have a lot of these symptoms that I've presented down below. So more likely to have the depression and the suicidal thoughts, as well as some of these difficulties in adulthood. So let's think about an anxiety disorder in the sense of it being a risk factor, okay? And risk factors are things that none of us want, but a risk factor does not mean that it will actually occur, that the negative outcome will come true for sure. So when it comes to, say, depression, we do see about 20% of the population, maybe it's up to 30% of the population does experience depression at some point, and those numbers might jump to 30 to 40% for individuals with an anxiety disorder in their lifetime. So it is a slightly increased risk, but again, it doesn't guarantee that those negative outcomes will occur, and if the individual gets treatment and the interference has dropped, you can actually, highly reduce the likelihood of those outcomes occurring for that individual.
Okay, good. Thank you for clarifying that, because I think this parent kind of gulped when they saw that.
Absolutely.
What links, if any, do you see between OCD and anxiety?
Well, so OCD is definitely an anxiety disorder. It is slightly different in both its presentation as well as its treatment. So individuals with OCD tend to have a little bit more of a feeling like it's irrational. Some kids with general anxiety do as well. They may say, I know that the anxiety is too high in that social situation. But there's sort of even more of an irrational component within OCD. We almost call it stretchy logic. So for instance, like we said with the hand washing, the person could say, it never will happen that if I wash my hands 6 times, I can guarantee that it's absolutely perfect. But the person who may have some social anxiety has that likelihood of it turning out to be poor in that situation, and they may think it's 50% likely that the social situation will go negatively. So they may believe it a little bit more. When it comes to treatment, the crux of the treatment for both of them truly is the exposure component. So approaching those anxious moments and sticking with it, and I think that that's the crux of anything I'm trying to convey here tonight, which is that anxiety itself is not a bad thing. We just need to know how to manage it to help it either get better in the future, or unfortunately, if we avoid it, we tend to see it growing and getting stronger.
Okay. So there are, going back to the question, there are some links between the OCD and the anxiety. But if I understand you correctly, the feeling with OCD is that it's probably not going to go away even if I do these things, whereas the feeling of success is better with the anxiety.
Right. So exactly.
With treatment within the anxiety, if I'm saying that correctly.
Yes.
Okay.
And they're both. What tends to happen is also we do see if one person has any of the anxiety disorders, there is a higher prevalence of having an anxiety disorder in the family. So we do think there may be some genetic links among all of the anxiety disorders, as well as the presentation and the treatments definitely go together well enough that they're almost like cousins.
Okay. So by the same token, you could kind of make an analogy then between anxiety and Tourette in terms of it being kind of an underlying thing that occurs with Tourette as well.
Oh, for sure. And very similarly, and we talk about this quite a bit, it is controversial for sure, but a lot of the treatments now for tics include what is called habit reversal. And there has been some research in the last few years coming, I believe, out of Norway or Sweden. The individual actually who had done this study investigated whether or not habit reversal was needed, or if you can actually just do exposure to having an urge to tic. And his results showed that they were actually very, very similar with regard to outcomes for the individuals that he was working with.
Okay.
Quite interesting.
Yeah, I'll say. Would you elaborate a little bit more on the use of coping thoughts?
Sure. Coping thoughts, we think, are extremely helpful with regard to engaging in those anxious situations. So if we're thinking the worst case scenario is absolutely going to happen, we almost want to poke holes in that thought and make it be so that the individual can see, okay, maybe it's not 70% likelihood that I'm going to fail this test tomorrow. Maybe it's 20%. We want to have a little bit of, give anxiety a little bit less control. In addition to that, we want the individual to be able to boost their confidence, not only in challenging the specific situation, but also feeling like I can handle this anxiety. So we tend to use coping thoughts in different ways at different times, but overall they tend to be quite helpful in helping us take that next step. And without them, I think a lot of times the anticipation of that worst case scenario tends to actually almost make us freeze. We can't take that step without thinking, okay, there's that potential for it to be slightly okay. But without that, we do think it would be much, much more difficult. And again, we are asking children and adults to do the things that they're most afraid of, which none of us want to do, right?
Exactly.
But if we can help them to see it in a different way slightly, it can help them to make that less scary for them in that moment.
Okay. This parent likes the idea of giving your child's anxiety a name. Mm-hmm. It's very visual, dealing with it like it's a thing rather than a thought. So you can take it out and look at it and talk about it and ultimately put it away. So the question is that like a very simplistic thing about that idea, or is that kind of what you're doing in that sense of giving it a name and changing it from a thought to a thing?
Well, that ability to externalize the anxiety is really helpful. I think both for the family, the therapist, and the child to get out of the struggle with it with the child, because a lot of times it is sort of us asking the child to change. But if we're asking us to change how we react to the anxiety, no longer are we telling the child that they're doing something wrong. Because I think that's the biggest concern that a lot of children do have in these situations when their parents are telling them to not be anxious, or their teachers are asking them to try to manage it better, with great intention. And I think it really helps in therapy quite a bit with regard to having us align versus the anxiety. So, being able to draw it, come up with a name. I love all of those concepts. The only thing I will say is that a lot of the times we use it as a way to approach it as opposed to trying to put it away.
Okay.
It is still quite difficult for children to detach from it so much. I mean, think about even anything that we would be anxious about. Being able to externalize it a little bit helps to challenge it, but I don't know if the individuals that have an anxiety disorder would be able to simply just take it and almost put it on the shelf. It would be great if they can. So, by all means, see what you can do. But
you guys would be out of a job, right?
Yes, that wouldn't be such a bad thing.
Okay. I have something that's kind of a mix of a comment and then a question. But
Okay.
I think it's kind of universal. This mom says that she has a fair amount of anxiety herself.
Mm-hmm.
And so she finds it difficult to watch her daughter struggle. So her
Absolutely.
question is the treatment for adults the same as you've described for kids? And how long would therapy last for a very motivated parent?
Well, so the treatment principles are the same for sure, in the sense that we take the thoughts, we take the actions, and figure out how it's maintaining the anxiety. And inevitably, we do encourage that exposure concept to occur as often as possible. And the more exposure we have, the less anxiety the individual will have in the long run. So motivation...
oh, sorry, go
ahead.
ahead.
So
if
motivation,
you were a motivated parent, then, how long would you say that would take?
Again, it depends on the disorder, it depends on the level of interference, but even with our adult patients, even those who have had anxiety for 20, 30, 40 years, they can do quite well in that 12 to 20 week window if they are highly motivated both in session as well as outside of session. So that's something I didn't sort of highlight throughout this, is that we do talk about the treatment almost like as if it's a coaching model. So we provide information, we provide skills, we provide a way of working towards challenging the anxiety, but the actual real treatment gets done more outside of our sessions in the person's real life. And if they can carry that into their real life regularly in between their sessions, that is sort of when we know that this individual is going to have no difficulties with reaching their goals towards the end of treatment. And sometimes we have had some kids come in and literally, and adults, and literally have 8 to 10 sessions and they've mastered pretty much everything because they were beyond motivated. Again, it depends on the individual, but that 12 to 20 session protocol is still pretty standard for adults.
Okay. This is from a teacher, and she has a question about accommodating students with anxiety, and how can I help an anxious student manage without detracting from other students' experience? And second half of the question really is, how much of this is her job versus the parent's job? So.
Right. It is quite a difficult scenario, especially if there is not someone on board who is working with the family on the anxiety. It's a very sort of detailed question, and I would like to have a little bit more information to give you more specifics on that. But I do, with any child that I'm working with, I do want to tend to include teachers in the dialogue about whether or not the anxiety is interfering either for the child and or for the school or the classroom itself. So, in general, I'll encourage teachers to help out the child in whatever way is possible. And that would, of course, depend on the child's type of anxiety and when it's most likely to pop up. So for instance, if a child is concerned about finishing their exams in a sufficient amount of time because they check their questions too often, if there's no treatment on board right now, I would encourage the teachers to give that child a little bit extra time so that they can let the child meet their potential educationally and prevent the anxiety from interfering as much in that moment. Over time, though, of course, I would encourage the child to be getting some type of treatment so they don't need that accommodation in the long run. But if the child is actually disruptive to the classroom, unfortunately, I think that becomes, clearly a school concern, and they may, also encourage the parents to obtain some types of services so that it won't be as interfering in the school system. But those types of questions are, exactly what I would be encouraging teachers to be thinking about. But again, like I said, without more details about what the child is experiencing, and you can always send that to that website with your questions a little bit more specifically.
Okay.
But yeah, you would need a little bit more background info on that.
Okay. All right. I think we have time for one more. And this question is from a school nurse.
Okay.
She's seen children with severe anxiety, but at times it seems like the parents make the situation worse. And so she has a question about the focus of the treatment. I mean, if she's observing that and observing the parents are complicating it, what advice can you give to her about that?
Absolutely. I mean, we tend to see, anxiety is very self-reinforcing, both for the individual in its avoidance, but also in the family, because again, it is quite difficult for individuals to see their children experience such distress, and also, it is difficult for parents to just sort of let their child flounder a little bit, and maybe experience more interference. So a lot of times there is that natural inclination for parents to step in and either accommodate or the parent's anxiety may actually step in and make the situation even more of a heightened, anxious situation for the child. I do think that it is important for any professional, if they have that clear picture, to potentially point it out to the parent. I know that those are the hardest conversations to have, but describing how you can see the child perform in one situation and also see how if the parent is acting in certain ways that are exacerbating the anxiety, we can tend to say, okay, so this is something that we've seen, and we actually think that if you want to try, almost like experiment with it, see if you act in this way and maybe it'll help the child, because I've seen that work pretty well. Again, the ultimate goal is to benefit the child, and I think if we all sort of keep that in mind, those difficult conversations are easier to have, but definitely discussing it with the parents, because talking to the child about it probably won't get you anywhere.
No, I don't think so either. But I can appreciate the position, though. It's difficult sometimes to make that connection. Well, I'm going to wrap it up here. Dr. Antinoro, thank you so much. Great presentation, and thank you, everybody, for attending.
Thank you for joining Thank you for joining our webinar on child anxiety. What does treatment entail for the child and family? There is an exit survey which we need everyone attending to fill out. The discussion board is now open and available for the next 7 days for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Thank you for joining. Thank you, and our next presentation is on building positive environments for the anxious child, presented by Sean Eubank, and is scheduled for August 17th, 2011. This ends tonight's webinar. Thank you, Dr. Antinoro, for your presentation, and thank you, everyone, for attending. Good night.